So, can I have the sound, please? So, this is a patient undergoing penetrating keratoplasty, and you find that the surgeon has taken out the nucleus, the posterior lens capsule is intact, and now the IOL implantation is being tried. The problem is the PC initially was intact, but now it's given way, and now an anterior vitrectomy is being done. So you see a lot of time is being wasted. Now you can see a whitish reflex at the back, and that is a cause of worry. And actually, a surgeon has to recognize that sign and be very careful not to be wasting any time. But here you see a lot of time was actually wasted, and then suddenly when the reflex starts changing, a panic button is stuck, and now the surgeon is really speeding up, trying to put the corneal button in place, but the battle is already lost, where you have all the intraocular contents just coming out and you're not having any time to actually salvage the eye or to suture the corneal button in place. So we have to be very careful of recognizing these very early subtle signs where things are not really working in the right direction, and you have to close the globe as early as possible without really thinking of implanting the IOL or doing other things. And the prime concern should be just to be closing the eye. So here you see there is a whole lot of bleeding now, and the battle is lost. So we really don't want this situation to occur, and you have to be very careful. So the course of action during and after a suprachoroidal hemorrhage is that you have to stop immediately once you notice something is going wrong, and even a moment's delay can actually cause a havoc, and you are not able to really salvage the eye. So the prime concern, as I mentioned, you have to seal all the incisions at once. And if you can increase the intraocular pressure once you have closed the eye, please do it as early as possible, avoiding further hypotony and further bleed from the choroid. After the suprachoroidal hemorrhage has occurred, you of course have to medically manage the patient. You have to control the intraocular pressure because there is so much of a volume increase inside the eye. You have to also control the inflammation, and then subsequently keep doing serial ultrasounds to see if there is any evidence of hemolysis of the blood in the suprachoroidal space. And like you see over here, the scan, what I have put, you see these echolucent spaces which are suggestive of the hemolysis. Don't be in a hurry to manage the suprachoroidal hemorrhage, because you would not be able to do a complete drainage of the suprachoroidal hemorrhage if you've intervened too early. So give adequate time. What I would prefer is to wait at least 3 weeks for the blood to liquefy and then to intervene so that I get a more complete drainage of the suprachoroidal blood. So the situation after expulsive hemorrhage is that the primary surgeon has actually surrendered. For him, the battle is already lost. Some bold decisions have to be made because you have to decide when to intervene, what to do. And it is actually a true war against blindness. So these are certain things which really intrigues you, and you have to really decide when to intervene and how to intervene in these eyes. So this is a small video of draining of the suprachoroidal hemorrhage. So an AC maintainer is put. A scleral cut down is made over here. And you see cyclodialysis spatula is used to drain the suprachoroidal blood. Oh, it's coming. So you have to see where is the maximum height of the suprachoroidal or the choroidal detachment on ultrasound, and that is the quadrant that you're going to target for draining the suprachoroidal bleed. AC maintainer is very important because you want to simultaneously maintain the intraocular pressure once the blood is being drained out. After you've done that, you can place a 6 mm infusion cannula. It's important to check the infusion cannula tip inside the vitreous cavity. If you're not sure, please do not switch on the infusion cannula and continue doing your work with the AC maintainer. It's important to put in your trocar cannula straight and not beveled. And like Dr. Andrew just showed, whatever residual bleed you have can be actually drained by partially inserting the cannulas. Now you can just go in and clear the anterior chamber, clear all the blood clots inside the anterior chamber so that you get a much better view to continue your posterior segment surgery. So here you already have a lot of retinoretinal adhesions which have occurred secondary to the suprachoroidal hemorrhage. So you have to be very patient in separating out these retinoretinal adhesions. You've placed a small amount of PFCL to protect the posterior pole. And gradually you peel all the membranes, opening up the retina. Now it looks much better where you can appreciate the posterior pole. You sometimes have to resort to making a relaxing retinotomy to clear out these huge blood clots under the retina. And gradually you have to keep injecting the PFCL till the whole retina settles down. And subsequently you do a laser photocoagulation to reattach the retina after fluid air exchange. You may be left with some amount of a choroidal bulge, which can be just left alone as it gradually settles down, and after this you can do a PFCL silicone oil exchange. So this patient apparently was a one-eyed patient, and we have a 6 months follow-up of this patient where he did get back a vision of 660 and he was ambulatory after having undergone this disastrous complication subsequent to a penetrating keratoplasty. So thank you so much for your patient listening.
Thank you. Very challenging indeed. So do you usually wait a little while for the blood to hemolyze before you do the surgery? How long do you wait?
I usually prefer 3 weeks, 2 to 3 weeks, but I surely don't intervene before 2 weeks.
Yeah. Question?
Yep. Some surgeons have tried using TPA in multiple quadrants in suprachoroidal space so that they can operate early. What is your...
I've heard of that technique where they've used TPA for an early hemolysis of the blood, but I still don't have any personal experience of using that technique.
Manisha, what's your first indication that something's going wrong?
First indication?
Yeah, the first indication, like you know, in cataract surgery, you've got an open sky
Right.
PK, but just say in cataract surgery, or in the old days in which we used to do extra cap, you sense something's going wrong. So what's your first indication? You said you don't want to be mucking around.
Right.
Yeah?
I think the first would be where you are having an undue upthrust. You're trying to put in the IOL, it's getting pushed out. You are having a slight change of the reflex that you're seeing at the back. I think that is something to be really recognized. And I think when you're having anything like this, I think the challenge is that don't persist with what you're trying to do and just close the eye.
I think one thing is like the glow that you are seeing, is there will be a slight eclipse on one side. I think that is the first thing you come to notice, that the glow is slightly reducing from one side. And that is the point you have to stop.
Yeah.
Because I remember one case I was discussing with her earlier also. I had just completed everything, only the IOL has to be inserted. I saw the glow diminishing, but I thought like only it is just going to take few seconds to put in the IOL, and then I'll just close it and finish it off. But the suprachoroidal hemorrhage does not give you that much time also. So it was so devastating, it just came out. So I was not able to put the IOL. The IOL also came out, everything came out. So you have to stop there only. That is, I think, the best message for the cataract surgeon once they see that.
So, Sangeet, is this modern sutureless surgery where you had that case?
Yes, sir. I think that the incidence is now much less when we are doing a closed chamber surgery. But still, we do have seen happening these kind of things even after a closed chamber surgery.
I think where we go wrong is where we try to persist with what we are trying to do. You know, if we have set our goal that we have to put in the IOL, we just tend to ignore the subtle signs and continue putting in. And the eye is telling you that something is going wrong. So I think it's best to just close the eye at that time and secure the section so that the things don't come out.